Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is the diabetic foot ulcer, a very challenging topic and very challenging part for an orthopedic surgeon. And definitely, how could I treat it by Ilizarov? Is it possible or not possible? Definitely, it is possible. And today our speaker is Professor Mofakharul Bari sir, the magnificent presenter. I would like to request Professor Mofakharul Bari sir to join with us. Sir, assalamu alaikum and welcome to our show.
Walaikum assalam. Thank you very much, Tanvir, for introducing me. Okay.
Thank you very much, sir. Dear viewers, we have three learned academic experts with us. One of them is Professor Manish Dhawan sir from Sir Gangaram Hospital, New Delhi. I would like to request the very honorable Professor Manish Dhawan sir. So welcome to our show.
Thank you. Thank you very much.
Thank you very much, sir. Another one, our very enthusiastic surgeon, Dr. Shamsul Huda sir from Patna, India. I would like to request Dr. Shamsul Huda sir to join with us. So welcome.
Thank you and very good afternoon, Dr. Tamir.
Thank you very much. And dear viewers, we have another learning academic expert, that is Professor Navikov sir. He will join with us in the coming part of our program. Now, I would like to request Professor Mofakharul Bari sir to start his magnificent presentation. And our topic is the diabetic foot ulcer treated by Ilizarov. Is it possible or not possible? Professor Mofakharul Bari sir, would you please share your screen with us?
Okay. Can you see my slide?
No, yet not, sir. It's coming.
No.
It's coming.
It's coming.
Yeah.
Yes.
Yeah, we can see your slide clearly and hear you loudly, sir.
Okay. Thank you so much. And my dear friends and dear viewers, friends, especially Professor Manish Dhawan and young friend Dr. Shamsuluddha, and my another good friend from Kurgan, Professor Novikov, and Tanvir, who is conducting the session all the time. And today I'm going to talk on very important and crucial issue, the diabetic foot ulcer. The management of diabetic foot ulcer, how we can manage by tibial transverse technique, TTT, DFU by TTT, bone lengthening. I will talk on Bangladesh experience. Today, I'd like to say that I have an amazing experience and incredible training regarding this Ilizarov in diabetic foot ulcers. These are the institutions I always love to show. Our 1,000-bedded hospital in Dhaka, Nitor, National Institute. At present, I'm working these two places. And this is my center, this is Kurgan. And Thor M, always I love to show miracle of nature, Professor Ilizarov. And we are happy that in my country, we have the opportunity to showcase our talent. The Ilizarov technique is indeed like mathematical formula. With its infinite variations, it can be used in many clinical settings, frequently when nothing else can be done. You can see on the left side, Professor Shigirov. He is the very good expert and senior teacher who is giving training to the all foreigners. And in the below, you can see right side the horse. On that basis, Professor Ilizarov invented the bows and rings. Diabetic foot ulcers are typically chronic skin ulcers associated with deep tissue destruction around the foot and ankle region, with varying degrees of lower extremity vasculopathy and neuropathy. DFU is associated with high rate of morbidity, disability, mortality, and socio-psychic cost. Now, challenge of diabetic foot ulcer management. The most common impaired chronic wound condition is in diabetic mellitus. 8% of population is estimated to suffer type 2 diabetes in 2035. 4% of diabetic patients develop foot ulcer each year. That means 15% during their lifetime. Diabetic foot refers to food infections, ulcers, or deep tissue destruction caused by peripheral vascular and nerve lesions. Diabetic foot are one of the most chronic complications of the diabetes, and severe cases can lead to amputation. Challenge of diabetic foot. Again, you can see here 85% of amputations are caused by foot ulcers. The relative risk of lower extremity amputation in diabetic patients is 40 times higher than that of non-diabetic patients. The 5 years mortality rate of patients with diabetic foot ulcer associated with amputation is about 50%. The mortality rate of Wagner 4 grade diabetic foot patients without surgery was as high as 54%, significantly higher costs and social burdens. Novel and cost-effective management, nowadays you should have to go for that. And if you think about the Professor Ilizarov's destruction histogenesis law of tension and stress principle, this is the main important thing. The TTT, that means tibial transverse transport technique, is based on Ilizarov's law of tension and stress for limb degeneration and functional reconstruction. The principle is that when appropriate tension is applied to living tissues, it promotes cell division and differentiation of adult stem cells like that in the fetal tissues development and lead to tissue regeneration. During and after TTT treatment, the patients reported immediate, very important is this pain relief, a feeling of warmth in the diseased limb, and the quantitative angiography confirmed the confirmation of rich neovascular networks in the diseased limb or ischemic areas. Destruction osteogenesis promotes capillary and vascular network and regeneration, and bone transport technique can significantly improve the microcirculation and soft tissue wound healing. Now let us see what are the biological mechanisms. So biological mechanism number one, corticotomy, immediately reduces the intramedullary pressure. It improves microcirculation of the small vessels in the medullary cavity, improves the arterial supply as well as venous drainage, pain relief, and raising of limb skin temperature within 24 hours after TTT surgery. Again, I'm going to talk on the law of tension stress. You see what it gives. This tension stress mechanical stimuli promote formation of new vascular network. Number two, gradually it improves the distal circulation. That is the very important, including the arterial, venous, and lymphatic circulation networks, and promote the reformation of all collateral circulations in the affected limbs. That is the beauty of Ilizarov on the basis of law of tension stress. Now, in Kurgan, evidence suggests that TTT may mobilize stem cells systematically, especially promoting recruitment and migration of mesenchymal stem cells towards the damaged tissues, mediating the local inflammatory responses, improving the local microenvironment to facilitate tissue repair and regeneration. And dear friends, if you think about the pathology of diabetic foot ulcer, then we can say this is the most crucial pathogenesis of DFU, diabetes vascular lesion. It is characterized by extensive lesions, especially the main vessels, calcification and stenosis, which leads to ulcers, disability, and mortality. And overall, 44.5% of the subjects were found at risk of DFU. This risk was higher among the men, 45.6%, than women, and men among those who lived in the rural areas, 45.5% as compared with the urban population. I am talking about this one regarding the Asia population in Southeast Asia. Primary care physicians and diabetes patients usually have a low-grade awareness of diabetic vascular lesions. Microvascular lesions increase blood viscosity and blood flow disorder, which are the pathological bases of DFU. Now you can see this foot right side, causes of microvascular lesions, metabolic disorders, of course, very important, hyperglycemia, hyperlipidemia, high glycoprotein, and other pathogenic factors leading to atherosclerosis and stenosis or obstruction of the venous lumen. Now, what are the causes of the microvascular lesions? Diabetic patients likely suffer more severe lower limb ischemia with the foot neuropathy. DFU is usually attributed to peripheral neuropathic denervation, very important, peripheral neuropathic denervation, and sensory abnormalities resulting in infected wound ulceration, such as rugates, this is means cracking, emphyrosis, firing, or abrasions, which are difficult to heal. The DFU consists of peripheral vascular disease, which is related with the last Friday. I talked on the peripheral vascular disease, especially Barger's disease, Barger's obliterans. Here is also same peripheral vascular disease, peripheral neuropathy, and local infection. Peripheral vascular disease and neuropathy leads to ulceration and gangrene, inducing infection that is again going on vicious cycle. And conventional standard methods of treatment with the doctors we know, but regarding the further treatment management of the surgery, before doing that, you should have to control all these things: blood glucose control, blood pressure and lipid control. For patients with kidney disease, malnutrition, hyperproteinemia, nutrition supplement therapy is needed to correct hyperproteinemia, anemia, and electrolyte imbalance. Microcirculation and nerves condition should be improved. Now, principles of debridement is very important. As soon as patient is hospitalized, you remove the black and yellow necrotic tissues. And if the necrotic toes have to be amputated, the joints cartilages remain retained because the cartilage surface can protect the subchondral bone and the necrotic cartilage will be drained naturally. Treatment of infected lumens, debride and limb the wound open. And the principle of dressing change after debridement, dressing shall be changed daily. The wound shall be washed with furacilin solution, or you can use betadine or iodine with saline water. Now, protocol for TTT surgery. This is very important for the orthopedic reconstructive surgeons. Basic requirements: the surgeon should understand the principles of TTT, tibial, transverse transport, and the indications and the contraindications. And indications are complicated, chronic and severe diabetic foot wounds. And inclusion criteria are, dear friends, diabetic foot with Wagner type 3 and above. I'll talk later on the classification of the Wagner and other classification, and Texas class 3B and above. Diabetic foot which received debridement, dressing drainage is standard medical therapy over 2 months with no obvious improvement. Diabetic foot combined with type 2, 3, or 4, the patient is mentally stable, willing to cooperate with the treatment, and the sign of preoperative informed consent. Wagner classification, very simple, and this is accepted all over the world. You can see grade 1, skin is contact, grade 1, 0, that is 0, grade 1, superficial ulcer of skin or subcutaneous tissue. Ulcers extend to the tendon, bone, or capsule. Grade 3, deep ulcer with osteomyelitis or abscess. Grade 4, we can tell partial foot gangrene, and whole foot gangrene is grade 5. Now, next slide, you can see these are the sequential grades of the Wagner type 1, 2, 3, 4, and 5. 0, skin intact, that's why I have not mentioned here, and these are the 5, grades. Now, let us see, somebody is also talking about this Texas staging grade. Here is 4 grades, stage 4, grade 4. You can see here, A, grade 0, pre or post ulcerative lesion completely epithelialized. Grade 1, superficial ulcer not involving tendon, capsule, or bone. Grade 3, grade 2, ulcer penetration to tendon or a capsule. And grade 3, ulcer penetrating to bone or joint. If you think a stage B, you will get infection. Grade 1 infection, infection, infection. Very simple to memorize, to understand. C, you will see ischemia, 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 and ischemia. And last one, infection, ischemia. And you can see here ischemia, infection, ischemia. These are the 4 stages of 4 grades. Now, another one is a Petty's diabetic foot ulcer system. This is also, you can see here, perfusion, extension, depth tissue loss, infection, sensation, 5 categories. And you can see here, on perfusion, you will get normal one, non-critical PAD, critical limb ischemia, full thickness, bone and joint involvement, the infection, nothing, none, mild, and this moderate, here is the severe. So, what are the contraindications for doing surgery? Patients with mental illness who cannot cooperate with the doctor during the treatment. Patients diagnosed with other uncontrollable severe diabetic complications by endocrinologist. Patients are intolerant of anesthesia owing to cardiovascular complications or renal failure in the past 3 months. And superficial femoral or radial arteries obstructed, or no arterial branches anterior or posterior up to the ankle joint. Now you can see the neuropathic and neuroischemic foot repeat progression. High risk. Here you can see ulceration, infection, and necrosis. Whatever the vulnerability, neuropathy is always, you'll find immunopathy, infection, ischemia, of course, and impact on neuropathy. Signs and symptoms may be minimal. Nevertheless, pathology proceeds rapidly. End stage of tissue death is quickly reached. Window of opportunity is very limited. Immune system, nervous system is deficient. So body is not willing to do any kind of good things. And now, post-operative management. Whenever you are doing surgery, we always prescribe prophylactic antibiotic for 1 to 3 days. During the whole period, the wire holes should be cleaned with 75% alcohol daily. It is better. Debridement and change dressing after surgery. The dressing shall be changed daily. The wound shall be washed at furacillin solution or 1% iodine or saline water. To prevent damaging the granulation tissue, hydrogen peroxide shall not be used. Affected limb should be raised up slightly to prevent limb edema. Post-operative exercise is, of course, mandatory. What are the efficacy assessments? You can see walking distance. To measure the walking distance meter in unit time. 3 minutes you can allow initially. The size of the ulcer you must calculate. The ulcer size should be measured and recorded all the time, pre and post-operative, and every 6 weeks should be done. It is for 6 weeks. Whenever you are doing dressing, 1 or 2 days, 3 or 4 days, you can see the size of the ulcer, which is healing or not. Percutaneous oxygen pressure at the toes. The patient should rest in room temperature for at least 30 minutes before the oxygen pressure measurement, which may be done once a week. And these are the, ABI and TBI, ankle brachial index and toe brachial index in resting state, laser Doppler for blood flow, and digital subtraction angiography. You can do that. Now, current treatment offloading surgical debridement and medication, not always satisfactory, resulting in gangrene and limb amputation. 50% of the wounds do not respond to current treatments. Recent advantage, I am very much lucky that I have gained this kind of training from Kurgan, and Ilizarov discovered that phenomenon of rich vascular network formation during distraction osteogenesis for limb regeneration and functional reconstruction. The law of tension and stress, again, it comes all the time. Activate and enhance the regenerative potentials of living tissues, leading to regeneration of muscles, fascia, blood vessels, nerves simultaneously. Since 2002, at present, the bone transverse lengthening technique has been developed, optimized, applied for the treatment of diabetic foot ulcers in my center and Bangladesh Institute of Health Sciences. So here are the cases. You can see, dear friends, 58 cases, male 46. Of course, male always more than female, 12 female, age range 35-72, duration of the diabetes, 1 to 25 years, foot ulcer duration, you can say 3 days to 10 years, Wagner getting 2, 3, 4, and 5. And in the right side, you can see the diabetic foot ulcer grade system that I described you. And we treated most of the diabetic patients above grade 2, grade 2. So this is the procedure. You can see right side drawing. There are two techniques. You can here you can see I have drawn this one. This is, you can go, you can put your olive here, or you can do a drilling here by 2 K wire, okay, 2 mm K wire, or by drill bits. This is, you can put multiple drill holes, and then you can put your olive, or you can put olive first, whatever you like, your choice. So this is cross section you can see here, and this is the tibia and fibula. This is the way how you should have to then cut. This is rectangular, and then you lift up this one. So let us see this next. And unfortunately, this video is not working. See, I have, this is one way that I have put the olive first, then below the olive, I am just doing the osteotomy. This is the olive, then I have cut, then applied this Ilizarov apparatus. Now, this is another way you can see that last day, Professor Manish Dhawan was talking about that I have done a small incision and cut that one. Here, small incision, 1, 2, 3, 4, 5. And then you osteotomize longitudinally below this, drilling with 2 mm K wire, and then put the olives. Then you can fix all these olive wires with telescopic, this one long rod, with not telescopic, with long plate rods with multiple holes. One ring above, one ring below. So when you see, you will feel that you have done the osteotomy. You can put this, all the bars with the, connect all these bars. These are the olive from this side. We are distracting transversely to the lateral side. These are here 1, 2, 3, 4, 5. So when you will start distract, you just loosen this, tight this, loosen this, tight this, loosen this, tight this. 0.25 into 4 times a day. And this is the peripheral angiogram before surgery. You can see I always do the angiogram in case of TAO, and at the same time in case of diabetic patients, so that after doing a preoperative angiogram, you can compare how much improvement has occurred after their surgery. This is a beautiful blood circulation peripheral angiogram after the surgery. Now, I would like to show you some cases. See, this is ulcer of the diabetic foot with partial gangrene of the fourth toe of a 28 years old male treated elsewhere. Came to my center. You can see the fourth one, the black skin mark here. You can easily identify he was treated and then came to my place. I have done the multiple drill hole technique and applied Ilizarov. And see this one and this one. And what happened? And after removal of the apparatus, after 2 months, you can see this is already, circulation is good here. Skin color is changed. There is a black marking here. And there was a, fracture here in the little one, in the little toe. This patient with diabetes mellitus, 4 years non-healing ulcer. Look at this patient. He was looking everywhere, going there and taking all the time for the last 4 years, antibiotic and antibiotics. But no healing. 3.5 to 2.2 centimeter, 45 years old male, big ulcer. What I did, then you can see here, osteotomy, lower third. Are here console where multiple. This is the view you can see from this side and from this side. This is the osteogenesis here for distracting the bone, and you can see after applying, you can see the view of the red coloration of this here, and this is also almost healed. That ulcer you can see. Now you can see this is before and this is after healed ulcer. You can see here a smiling patient, no ulcer is here. So you can give a very good, beautiful service to the patient by doing this kind of beautiful magical surgery. So you can see here, dear friend, now I would like to show you the video, a little video. It must run. Oh, this is not running. I'm sorry. This is a beautiful animation. Why this is not running? Beautiful animation. This is not running. So I'm sorry. Next, I proceed. See, diabetic right grade 2, 40 years old female patient. Look at this. At the same time, you see the toe. See here. See here. What you'll do? Go for abrasion. It was done in 2015. You can see. And then I put the Ilizarov and multiple deal. This is mini Ilizarov. And then follow up. You can see after treatment, totally wound is healed. Totally wound is healed. Only increased circulation. Diabetic foot ulcer, bilateral sole of the foot, 40 years old male patient. You can see here, this is the patient, 45 years. Look at the foot, look at the foot. And then I started doing, these are the damage of the tarso-metatarsal joint here. And as a result, you can see here the ulcer. And I have started doing this operation in the right side. Same technique. If you look at these, this is olive, olive, olive. Go for transverse TTT, transverse tibial transport. Then, as a result, within a few days, you can see the ulcer is going to be healed. And this is the final view. This is the left one. I will do later on this one. From this situation to this situation, this is the right foot ulcer. It's healed. So, diabetic foot has rapidly progressive and complex natural history. Patient is very vulnerable. Care should be easily accessible, specialized and multidisciplinary care should be done. And in conclusion, dear friends, TTT technique for DFU, Wagner 2 and above, have successfully conducted more than 58 cases. We perform TTT along with routine debridement and dressing change. TTT technique can significantly enhance diabetic ulcer healing, increase the limb salvage rate, and reduce the DFU recurrence rate. But this technique was not 100% effective for severe DFU treatment. Many complications are attributed to lack of clear clinical guidance and training for the correct surgical protocol and post-operative management. The TTT surgery should be performed in minimally invasive fashion through a small incision with meticulous corticotomy with a fixation Ilizarov fixator to ensure a good stable fixation. And this is not in diabetic. It is published in TO, but procedure is almost the same. That's why I put this publication in 2015. And finally, these are all great mans. This is the director of the Gubin. Now Gubin is the director of the Central Institute of Moscow, Traumatology and Orthopaedics in Moscow. He's not in the Kurgan now. and this is all Kurgan giants in my village town, Gajipur. That is 30 kilometers from Dhaka. We had conducted a conference here in our center. We are doing almost every year, but due to pandemic, we could not conduct last year and this year. So I always admire the gentleman, scientist, great, talented doctor, innovator, gifted innovator, creator of the apparatus of the transosseous osteosynthesis. And why Ilizarov surgery, when you are doing, you are getting a lot of complications. Why? These are the main things that unknowing or knowing anything, somebody is doing Ilizarov, putting the wires, there is inadequate knowledge, improper technique, violation of the original principle Russian rules, lack of skill, intelligent meticulous follow-up, lack of patience and hybridizations. Confidence and hard work, the best medicine to kill the disease called failure. It will make you a successful person. And orthopedic, I always tell, learning orthopedic is very hard work, requiring long days and nights of study. Ilizarov gives art of learning. The art of Ilizarov requires specific commitment for a lifetime. So, dear friends, what is peace? How we can get peace? I always tell, perfect endeavor around the countries of the earth. This is called peace. And if I want to get peace, by doing this surgery, the fruit of silence is prayer. The fruit of prayer is faith. The fruit of faith is love. Fruit of love is service. Fruit of service is peace. By doing this kind of surgery, you can get peace. These are me almost 7 books. And within a short time, I'm going to publish a Subur extremity on Ilizarov. And home message, always I tell, evidence, science, and surgical skill. And I always convey my gratitude to Professor Gabriel Abramovich Ilizarov, Professor Shepsov. They are my mentor, and Gubin and other fellows from the Kurgan Center, and including this gentleman Novikov. Thank you so much, my dear friend.
Thank you very much, sir, for your excellent presentation. And dear viewers, you came to know that the diabetic foot ulcer can be treated by Ilizarov, and it is possible. We can make the impossible possible by the magical Ilizarov. Now, I would like to request Professor Manishwan sir to say something or to ask any question to Professor Mofakkar Khan sir. Professor Manishwan sir.
Yeah, I first congratulate Dr. Bari for such an excellent presentation. Very, very nice. And this technique really works. But I have a slightly different way of doing it. I also, get results with that. What I do that I do a multiple drilling of the cortex, like in tibia that it is a diabetic foot. I do multiple degree drilling in S-shaped fashion in the whole tibia anterior cortex with a 4 bit, and each drill hole is 2 centimeters spaced out, and then I apply the frame. So I also get the ulcers go away and there is increase in circulation. So there is slight variation in the technique. I just want Dr. Bari's comment in that.
Can I ask you, Josh, whenever you are doing A-shaped, what will be your size of the length of the bone, and how you put the olive wires or anything with the connecting bar, the plate, how you
No,
put that?
I don't apply olive oil. I just do the drilling in S-shaped fashion, 2 centimeter apart.
And nothing
Then
else?
nothing else, and then just apply the frame, and it works quite well because the
So
basic principle.
yes, this is okay, but you don't do any distraction.
No.
No. If you don't do any distraction, you cannot get good microcirculation of the whole body. Only you can get when you're drilling, you are decreasing the pressure over the bone. That's good. That is 100% correct. That is scientifically. Whenever you are drilling anything in any bone with K wire or by drilling bit, circulation will increase. That is true.
But Professor Bari, this the ulcers, they disappear. In my technique, also the ulcer disappear.
That is good. That is good. I agree. But if your ulcer is grade 3, 4, and 5, long ulcer, then when circulation, the pathology is here, microcirculation, vessels, nerves and vessels are disturbed, impaired here. Whenever you are doing destruction, you are getting new vessels, new nerves, new muscles. Everything is coming up. It is a little bit better than that. I agree with you, but this is already, I proved you, showed you that I have seen that is working well. Thank you for your.
Thank you.
Thank you very much, sir, for sharing your experience with us. Now, I'd like to request Professor Novikov, sir, to say something regarding the topic and to share his experience. Professor Novikov, sir, would you please say something?
Thank you very much for possibilities to see excellent magic presentation. Thank you, Bari, for your experience and for your knowledge, because just now you, like ambassador of our methods, give excellent, very important information for so many traumatologists, because diabetic foot, this is not our bread. This is what not field of orthopedics and traumatologists. But many years ago, Ilizarov was first in the world who support with osteosynthesis, with effect of Ilizarov, give chance for this poor patient. And just now in our center, we have special department, clear patient with diabetic foot, special staff, and excellent special orthopedic surgeon who know everything, because I think this is topic from our team who need know everything, including blood vessels, including hormones. Usually traumatologists think only bone, because this patient is healthy. But diabetic foot, this is very big problem with health, diabetic condition. And Dr. Bari, you are a great surgeon, and I want to congratulate you with so very good. Just now we can say this is your technique, Bari technique, and this is development of our methods. Very sorry, very important call. Ага, у меня, я думаю, уже заканчивается.
Dr. Bari, can I have a question with you?
Yes,
Yeah,
please.
Oh no, I think Professor Novikov has finished his call. Let him first speak.
Sir, Professor Novikov, sir, would you want to say
Давайте,
something?
вы говорите еще. Novikov, говорите.
Dr. Bari, what you think? This is patient need separate treatment, or we can support in general department, like trauma case, like orthopedic case, or this is a patient unique, and you need special treatment, special prescribe, special dressing. What do you think? This is normal orthopedic patient?
Listen,
In other?
I am at present working in diabetic food corner. We have a food corner, food corner, not food corner, diabetic food corner in the hospitals. All general surgeons are working there, general surgeons, but they are doing amputation. They know the technique, but they don't know how to apply this one. And I am privately in my center, and I'm doing this technique in this center. Now they know the literature, everything, but the technique that I started, now they know this one, general surgeons. You don't need to go for imputation. You don't need to go for, sequential imputation of the great toes, of the little toes. You can treat your diabetic patient with ulcers with this fantastic technique, I tell you. And I am saving most of the limb salvage doing here in Dhaka because of this technique, Ilizarov technique. Otherwise, because vasculopathy and neuropathy, you cannot create anything. But with this Ilizarov technique, you can create something. That is 90%.
And
If you see the literature, you can correct 90% of the diabetic food. Not 100%, 90% of the you can. If it is very severe,
but this is
long
90.
diabetic,
This is excellent.
aged patient, then you cannot do that. Very good result. Otherwise, 90% you can save the limb of the patients by doing this kind of surgery. TTT, transverse trivial transport. I showed you. I showed
colleagues, you see,
a lot of things.
second,
I showed you one case with, above the medial malleus. That person was running 4 years over here in Dhaka. In everybody is giving antibiotics, and he was taking 4 years only antibiotics, no help. Came to my place. I have done destruction osteogenesis and wire technique in the foot and destruction osteogenesis in the lower 1/3 of the tibia. As soon as I started, the color of the skin changed. The color of the skin
Dr.
changed.
Yeah, colleagues, you see, second topic, we talk about not orthopedics case, not trauma case. Second topic, we talk about excellent collaboration. Effect of Ilizarov give us chance collaborate with another site of surgery, with vascular surgeon and with general surgeon. This is effect of Ilizarov. I think next step when we will collaborate, for example, with neurologist. This is everything effect, magic effect of Ilizarov. And I want to congratulate all of us with our father, our genius, and methods, technique, which give us knowledge and possibilities to treat not only trauma and orthopedic case. And for Bari, thank you one more, because so many doctors in the world just now see Ilizarov and Bangladesh experience and possibilities for support with severe disease and severe problem. Congratulations, Barry.
Thank you, sir. Thank you, sir. Thank you very much, sir. I would like to ask one question to Professor Novikov, sir. Sir, do you have any special center for diabetic foot ulcer management there in your institution?
In our center, just now, we open a special department clear for diabetic foot, and there everything separate. Because separate. And only patient with diabetic foot stayed there, because this is special knowledge, everything special, including endocrinologist. Including endocrinologist and general surgeon. You're absolutely right, Dr. Bari. And this is patient not for trauma department.
Oh, don't you use any Ilizarov in case of the diabetic foot ulcer?
For this patient, we use Ilizarov technique with treatment. Heart treatment which prescribe endocrinologist.
Okay, thank you, sir. Professor Manujan, sir, want to ask something to Professor Bari, sir.
I just wanted to ask Professor Bari that in a series of 50 plus cases, has he ever experienced that once you have treated a patient and there is a recurrence? Have you noticed this thing?
Yes. There is a question. Recurrence is very severe patient is debilitated with very severe case, then you can get, if they don't follow the control of the diabetes, everything, sugar level, hyperglycemia, everything, then you can get recurrence rate. But percentage is, in my case, 2 to 3%. In my case, all 53 cases, 58 cases.
One question
That's
from
great. Sir, please, Dr. Shamsul.
Sir. After removing the Ilizarov, So, do you apply orthosis after removing Ilizarov in this diabetic foot cases, sir?
Sometimes I apply, sometimes no.
Okay. Not on regular basis.
Not all the time.
Right.
Because healing ulcer, ankle is okay. If patient is suffering with the ankle and other, charcot joint,
Right.
then I apply that one. Charcot joint, I'll talk later on.
Especially when there's need of weight distribution in the sole after Ilizarov removal.
Yes. And during when I'm doing charcot joint arthrodesis, then I go for AFO.
Right.
Charcot arthrodesis or charcot.
No in soles after that, sir. Okay.
Yes.
Sir, have you ever used PRP along with the Ilizarov?
PRP?
Yeah.
Plasma?
PRP
This
in case
one?
of that? Yeah, yes, sir. Yes, sir.
No, along with Ilizarov. No. Only Ilizarov.
No.
Manish, sir, have you been
Ilizarov.
using orthosis and PRP in your cases?
PRP?
Not PRP, but sometimes I use because of the sensation loss is there. So I give a special diabetic footwear, specialized footwear. Also in the footwear, I also see the areas where there was ulcer. So
Right.
we relieve the pressure over that area. I do it.
Yes. Thank you, sir.
Thank you very much, sir. Thank you very much. It's a great pleasure for us, as because of this is the new arena of treatment, that is the diabetic foot ulcer treated by Ilizarov. As the Professor Novikov sir said that this is the Bari technique, so I can tell that this is the not the TTT, this is the BTT. This is the BTT. Definitely, this should be the BTT, the Bari's transverse tibial technique, and that's a great honor for us. And I would like to congratulate and thank to our Professor Mofakarul Bari sir, as well as Professor Novikov sir, Professor Manish Dhawan sir, and Dr. Shamsul Huda sir for being with us. And I hope we will discuss in our next program with another peripheral vascular disease that can be treated by Ilizarov, that can be managed by Ilizarov. Until then, I'm Dr. Mohammad Tanvir Ashraf saying bye-bye to you. And definitely, I would like to thank Raj TV and Renata Pharmaceuticals Limited for sponsoring our program. And thank you, everybody, for being with us. Good afternoon, and bye-bye to everybody. Bye-bye.
Барри, ты меня слышишь?
Да.
Барри, зайди, пожалуйста, на сайт нашего центра. Там есть данные для обучающихся кафедры.
Хорошо.
И там есть перечень документов, которые нужно срочно выслать нам.
Хорошо.
Давай сегодня вечером ты открой, я открою, и вместе будем сидеть, смотреть и по телефону разговаривать, хорошо?
Okay. Спасибо большое. Manish, thank you very much. Shamsuluda, thank you very much. Tanvi, thank you very much.
Thank you, sir. Thank you.
Thank
Manish,
you.
sir, I would like to request one thing. Would you please share your trace with us that you have done
one thing.
hole?
And today one person, probably Manish, he's very most senior, near about 80 years. Dr. Chunnu from Mauritius.
You are
From
watching
Chunnu.
Raj TV, Jagorone, Bangladesh. Please subscribe our channel.